Good evening, everyone. It's an absolute pleasure to be here and telling you all about dentistry and a little bit about what I've been doing, finding out about how the dental system works in England and how we might do that a bit better. Yeah, we're going to just run through the presentation. I've got a few little interactive things to try. Hopefully the technology will work, but if it doesn't, that's fine. We'll just skip over those. And then, as Fiona's already said, we'll hopefully have some time for a few questions at the end. So I'm going to try and share my slides first of all. So yes, so this is all about how NHS Dentistry works in England and how could it work better. So just a little bit about me first of all. I actually grew up in Blackpool, in sight of the famous Blackpool Tower. I then went and did my dental degree in Sheffield, a lovely city, although I'm slightly biased now and hope you all come to Newcastle. And then came straight to Newcastle after graduating in 2004, almost 20 years in Newcastle now. And I've made this my home now and I've dragged my whole family up to the northeast. I absolutely love it here. So my current role is that I'm the head of the dental school here at Newcastle. I'm a professor of oral health services. In other words, how do we provide dentistry to the population? And as well as that, I still practice clinically. So I'm an honorary consultant paediatric dentist, in other words, a children's dentist at Newcastle hospitals. So what does that actually mean kind of day to day? Well, it means I do research and I'm particularly focused on the area of oral health economics. I teach particularly our undergraduate dental and dental therapy students children's dentistry. My clinical work is all children who are referred into us by a general dentist. So I see kind of specialist level stuff. And I'm very lucky to advise on policy worldwide. So I work a lot with the World Dental Federation, but also within England, I do a lot of policy advice for NHS England as well. So it's a nice varied kind of career path. So that's just a little bit about me. I want to find out a little bit about you all, and in particular, your dental experience. So we're going to use this audience engagement system. So the first question that we're going to ask, which is open now, is, have you seen a dental professional, so a dentist, a therapist, a hygienist, a dental nurse, in the last 2 years? Oh, I can see you're all responding very fast. Here we go. And let's see what the answer is. It just takes a while to tot it all up. And nearly all of you have, so that's fantastic. And actually, we'll see in a minute, that is not reflective of the general population. Particularly through the COVID pandemic, that's been really difficult. So next question for you, have you ever had an extraction, a dental extraction, a tooth taken out? And it's just totting that one up. And, oh, interesting, quite a mix there. So a majority haven't, but it's a pretty close call. That's more than I expected, actually. So very interesting. Let's move on to, have you ever had a filling? There we go. And we'll top that one up. And yes, so again, most of you haven't had a filling, but a significant number have, more than I expected, perhaps, again. And then finally, have you had orthodontic treatment? I've made this one a bit more complicated. So have you had it in the past? Are you currently having it? Are you waiting to have it? But you know you're going to, or have you not had it and you've no plans to have it? Oh, a bit of a mix here. So most people haven't had it and have no plans to, but of those that have had it, about a quarter of you have had it in the past. 14% are currently having it and 11% are currently waiting. So yeah, I mean, that might be kind of what I was expecting, actually. So interesting, and that might bear a bit of resemblance to some of the figures I'm going to show you in a second. So this topic's really relevant, actually. So a few headlines. These were actually from over the last year or so, but I could have chosen all sorts of headlines. And real problems with getting care for your teeth. And so lots of people struggling to get to the dentist, people pulling their own teeth out with pliers, facing the worst crisis in its history, 3-year waiting lists. Yeah, so lots of problems with dentistry. And that's why I thought it would be really good to talk about this tonight, actually. And the BBC did some research with us in Newcastle University, actually, looking at the proportion of dental practices in different local authorities, so different council areas, who were taking on new NHS patients, adult ones. And the darker colours are where there are no practices or less practices taking on patients. And you can see vast areas of the country, and this is now a year old, and I suspect it might have got a bit worse, actually, who weren't taking on any new patients. And this idea that we might call these areas dental deserts came about, and a really significant problem but lots of practices not taking on any new adult NHS patients. So big problems for us in dentistry. And actually, the pandemic has made things much worse. So the top box here in the light blue looks at the number of children who have been admitted to hospital for extractions because of decay. And actually, these figures are absolutely huge and really depressing, although I see these people when I go and do my clinical work. And you can see that in 1920, so the year really before the pandemic, we saw about 40,000 children. And then that dropped through the pandemic to 16,000. We had real problems getting people into the NHS to get their care. So it wasn't that decay had suddenly got better, it was that people couldn't access the care. And then in 21 to 22, we saw some recovery, but not back to normal. And we think we might have just about got back to pre-pandemic levels of activity again now. So decay isn't going away, but we have had a whole chunk of people who have really struggled to access the dentist and access hospital services in particular, and therefore they haven't been able to access their care that they need. Excuse me. And the next two boxes talk about the people who are seen in general dental practice, kind of high street dentists. And again, we can see that of the 10 million children there are in Britain, or in England, I should say, the number of children who had seen a dentist in the 12 months up to June 19 was about 7 million. So quite a significant number of children not seeing a dentist in any one year. And then that dropped right off in the pandemic, and we're still not back to normal, unfortunately. And there's now 40% of children who haven't seen a dentist in the last 12 months. Really bad news, actually. And then adults, it's even worse. So less than half of adults were seeing dentists in 2019 before the pandemic. And that's got much worse through the pandemic and is only just beginning to recover again now. So big problems with access to dentistry. So we've got a bit of a backlog of care, lots of disease stored up that hasn't been treated, and all sorts of problems there. So why might that be? Well, the pandemic's part of the problem, I think. People say, oh, we got enough dentists. Well, that might be a problem. I suspect we might have just about enough dentists. We might need a few more, but actually it's whether the dentists are in the right places, doing the right things. And therefore, the next question is then, do we have enough NHS dental teams? And actually, do we need just dentists, or do we need other types of people like therapists and hygienists? Do we need to import dental professionals from other countries? That's become harder after Brexit, actually. We've lost a lot of dentists through that, and we know that we're still struggling to make up for that. There's a lot of talk around whether the contract that dentists have to provide NHS dentistry is good or bad, and I'll cover a little bit of that through the talk. Are we using the dental team most efficiently? Are people doing what they could be doing with their time to the best degree? Is NHS dentistry actually providing the right things? Should we be concentrating on some of the more important things? And again, I'll cover a bit of that in the talk. And then, are we doing enough prevention? If all these people need to come to the dentist, that suggests there's lots of disease. Could we actually do more to prevent it? So that's some of the questions that are kind of floating around that we'll maybe begin to address through the next half hour or so. So, the next question really is, why do we need to have an NHS dental system at all? And that leads to two further questions. Is oral health important? And if it is important, do we need a public system, a publicly funded system like the NHS, to actually deal with oral health? So let's have a look at oral health first of all. So these are some of the stats that we measure. And again, Newcastle have been heavily involved in gathering some of this data. And a quarter of 5-year-olds have had decay experience by the time they're 5. Now, you kind of think, oh, yeah, that's fine. They're just numbers on a page. But that's really terrible, actually. I mean, dental disease is a preventable thing. And a quarter of people, by the time they're 5, have already got decay in their mouths. And we're really not doing a very good job in preventing them getting that decay. We did another survey of 3-year-olds. It's quite tricky to do a survey on 3-year-olds and get them all to open their mouths and let us have a look inside. But we found that even by the age of 3, they've only had some of their teeth for a matter of months by that point, but 10% of them have already had dental decay. And much older data for 15-year-olds, we haven't done this for a long time, but by the time people were 15, nearly half of them had had decay. And that's a preventable disease, and half of people have had decay. The other real problem with decay is that it depends very much on where you live, how much you have. So this is a graph of the different council areas in the northeast. You may not be able to read it, that doesn't matter. And it's the amount of children who have experienced decay. And you can see on the bar on the left-hand side, that's quite tall, that's 40% of children in that local authority, that council, have had decay. And that particular council is Middlesbrough. And then at the other end of the spectrum, at about 12%, is North Tyneside, and they have a much lower decay rate. And that's a huge difference, 40% to 12%. So there's a real problem with where you live. And we know that's associated with how deprived the area is, but also how much fluoride there is in the water. So they're really important things that determine how much decay there is. But the main message here is that there's too much, I'm afraid. And it's really sad. And so this graph actually shows all of the local authority areas in England, and this is the average number of teeth that a child has affected by decay. And you can see in the worst areas, that's 2.5 teeth, and in the best areas, it's 0.1 teeth. And so a huge difference between different areas in England. And we know that children from more deprived areas, 33% of those or more have decay, compared with 13% in deprived areas, affluent areas. And we know that certain ethnic groups are much more likely to have decay. So it's much higher in people who classify themselves as other ethnic groups, and those who classify themselves as Asian or Asian British. And in terms of the impact of all of this, so, decay, well, that's fine. It doesn't really matter whether people have decay. Well, actually it does, because a quarter of 12-year-olds who are deprived, eligible for free school meals, have had some sort of toothache, compared with only 16% of those who are more affluent and aren't eligible for free school meals. And that's a way that the National Statistics Office measure how deprived people are. So huge differences in the impact of this decay as well as the amount of it. And that all leads to problems. So it can lead with problems with growth. So children don't grow as well if they have got decay. We know that children and adults will get more embarrassed if they've got decayed teeth. Obviously, they will get pain. They might have difficulty eating. They won't be able to smile as well and might hide their smile. We know there's good evidence now that it affects school performance, and it also affects sleep, which is also really important to our health. So decay has a massive impact on people. These are figures from the Child Dental Health Survey, but we know that most of those things also apply to adults as well. And in 2015, 25% of teenagers stated that their teeth had affected them in some way in the last 3 months. So this is a massive problem. If we had a quarter of the population having heart problems, there'd be an absolute uproar, or a quarter of the population having problems with their kidneys, there'd be an uproar. But in dentistry, we just kind of accept that this is normal and that it's fine for a quarter of the population to have had some problem with their teeth in the last 3 months. And all those figures are a bit boring, actually. So it's often a bit more hard-hitting if I tell you some stories about my clinical practice. And so this picture on the left here is a picture of one of my 3-year-old patients. And she came in to see me, and you can see she's got lots of decay in lots of her teeth. It doesn't take an expert dentist to be able to diagnose that decay, but that's a really significant problem for her in terms of the pain she's suffering, but also in terms of how she looks and how her friends at school are going to treat her, and friends at nursery. And then this jar of teeth isn't actually me, it's one of my colleagues who works in Manchester, but she collected together all the teeth that she'd taken out in one afternoon of practice and put them in a jar, and that's become a very famous image that she's used a lot to make the case that dentistry is a problem. I actually counted up the number of teeth I took out last week on my general anaesthetic list, where we put children to sleep for this, and I took out 88 teeth in 10 patients. And that's absolutely shocking that we're taking out so many teeth in young children, and it's not a pleasant procedure. So there really is a problem with oral health. So I hope I've illustrated there from a children's point of view, but equally it's very important for adults, that oral health does matter. So that brings us back to that other question I asked: do we actually need a public system to deal with oral health? And I'm going to get into some technical economic terms here. You don't need to remember the terms, but you might understand the principles behind them. And the first technical term is something called information asymmetry. And the argument here is that with healthcare, the consumer, or the patient, as we like to call them, isn't fully informed about what they need or the quality of what's provided. So if you have a health problem, you'll go and see the doctor, and they will diagnose it and say, oh, actually, and this is the procedure you need, or these are the options you've got. You don't know what those options are often. And so we're reliant on the doctor or the healthcare professional to tell us what we need. And when we go and have a heart operation, hopefully not many of us have to, but when we do, we've no idea really about the quality of that heart operation. We don't know whether what they're doing is good care or bad care. We know whether their interaction with us is pleasant or not, but we don't know about their stitching ability or whether they've done the right technique to open the heart up, etc., etc. I'm not a cardiac surgeon, so I don't know the technical details, and that's the point of this, really. Contrast that, for example, with going shopping for food. We kind of know what food we need, what we like, so we can go and shop for a tin of beans if we know that we want some beans that day. We've a fairly good idea about how to judge the quality of those beans, and we know which ones we like. And yeah, we might choose a big brand or an economy brand, but we can make relatively informed choices. But in health, that's not the case. So we're reliant on others, healthcare professionals, to make a decision for us about what's needed, and reliant on them to undertake good quality care. So dentists, along with other healthcare professionals, act as what economists would call agents, i.e. we're both the supplier of the care and we're the person advising whether we need it. And you can see that that creates a bit of a conflict of interest for the dentist, because if they were unethical, they could tell you that you need something that you don't need in order for them to be able to then provide it and make a profit. And so that puts the dentist in a really difficult position. And that's part of the reason, I'll explain why in a second, that we need a regulated system of national health care publicly provided. And I'll come on to exactly why in a second. Another reason that we need a publicly provided regulated system is that it's very difficult for us to predict when and if we might need dental care. We don't know when we're going to develop pain. We don't know when we're going to develop a cavity. And we don't know exactly what we're going to need when that happens. And that means that we can often be exposed to unexpected or very large expenditure if there isn't some kind of system in place. And so nearly every country in the world now has developed some kind of insurance system for health, or they've used a tax-funded system to create a public system. And that means that essentially the risk of needing to spend lots of money on healthcare is spread or mitigated against because there's an insurance system or a tax system. And that's one of the reasons. That, unfortunately, though, creates a second problem and what the economists would call moral hazard. And this is where patients, because they're not actually paying directly for their care, are motivated to demand extra care. And it also means that dentists might be less worried about providing excessive care because it's not going to be a financial burden on the patient. So imagine for a minute that you're paying into an insurance system and you think, well, I'm paying all this money in, but I'm not actually getting any healthcare because I'm very healthy. So you kind of think, well, what could I get? Well, I might get something that's, you know, maybe not directly healthcare related, but might be a diagnostic test. Like I might go for some extra scans just to check I'm healthy, to make sure I'm getting my money's worth out of the system. So that would be moral hazard. And so, therefore, because of those three things, information asymmetry, moral hazard, and the risk and unpredictability of dentistry, we make various interventions because it's what we would describe as an imperfect market in economics. And so in dentistry, we've got a register of dental professionals. So in the UK, the General Dental Council is our regulator, and you have to register with them in order to be a dentist. And that means they can make sure that we've only got ethical dentists that are practicing. The same for therapists, hygienists, nurses. As part of signing up to that register, the dentist, dental care professional is required to share information with the patient and get informed consent. So that gets over that information asymmetry. The dentist has a moral and legal obligation to share all the information and be honest and truthful with the patient. And also, there is an argument that there should be quality checks because the patient can't judge the quality. Now, the old NHS system before 2006 in England did have quality checkers who went round and checked on the work of dentistry. That was all abolished, but there is an argument that maybe it should still be in place. And we also pool together our financial risk, as I've said, by having a publicly financed system or some kind of health insurance. And because of that, we need a list of permissible treatments that are available to the public on the public system. We have a list of set patient charges, and we pay dental teams in a set way nationally. And all of that is to address these problems of information asymmetry, moral hazard, and the risk of unpredictable expenditure. So that basically sets the scene to say we do need a public system for dentistry, and actually that argument could be applied to any of healthcare. So that then begs the question, if we need a public system like the NHS, what should it look like? And so before we move on to what it should look like, I'm just going to tell you what the current NHS system looks like, because actually this is quite complex and not a lot of people understand it. So from the point of view of the patient, the NHS dental system in England says that it will provide for every patient enough treatment to get them dentally fit. Now, unfortunately, it doesn't really define dentally fit, and so that's open to a bit of interpretation down to the individual dentist or dental care professional, and it's really quite difficult sometimes to justify whether that includes some treatments or not others. Now, there is a payment for dentistry, but it's a co-payment. In other words, you're putting in some money as the patient, and the government are putting in some money as well. And about 2/3 of adults have to pay. Children are exempt from paying, they don't have to pay. And adults on certain benefits, including pension tax credits, so older people, and pregnant mothers are all exempt from paying as well. And the pregnant mothers is a bit of a weird one. There are maybe some good clinical reasons, but you could argue that that's maybe a group that doesn't particularly need covering. And the payment that the patient makes depends on what is in your course of dental treatment. So you go and see the dentist, they say, in your course of treatment that I'm about to provide, you'll need X, Y, and Z treatments. And whatever the highest item of treatment is, that's what determines how much you pay for that course of treatment. So if the highest item of treatment is only a checkup or a cleaning of your teeth or an x-ray, then you are in what we call band 1, and you pay £24, and that covers everything you need doing. If you need a filling, a root canal, or an extraction, or more than one of those, then you fall into band 2 and you pay £65. And if you need anything like a crown, a bridge, or a denture, then you fall into band 3 and you pay £283. And that is about 75% of the cost. So the dentist will get the other 25% from the government. Now, it's a really weird system because if you need one filling and nothing else, you would fall into band 2 and pay £65. If you need 10 fillings and nothing else, you still fall into band 2 and you still only pay £65. You don't pay £10 times 65. So it's a bit of a weird system, and actually there's a real incentive for patients to sort of store up the treatment and see if they can get all the treatment done in one course of treatment. So it is a bit of a weird system, and a lot of people are really unhappy about it. From the dentist perspective, the system is built on units of dental activity. And the dentists earn these UDAs, units of dental activity, based on the highest rated item in the band of treatment they're providing to that patient. So if they see a patient and they need to do a denture, they'll get 12 units of dental activity. If they see a patient and the patient needs 3 fillings, there'll be a band 2 patient and the dentist will get 3 UDAs. However, of course, if the patient only needs 1 filling, the dentist will still get 3 UDAs. So for the dentist, there's a real incentive for them to try and do the minimum amount in each course of treatment, because if they only need to do 1 filling, that will only cost them 1 filling and they'll still earn 3 UDAs. And the practice will have a contract with the NHS to provide however many thousand UDAs per year for a set amount of money. And that's the way the system works for the dentist. And just in terms of how the money flows through the whole of the system, then there's about £4 billion that the government puts into dentistry. We know that about 30% of patients go private, but the remainder go to dental practices. And as I've already said, 66% of them would pay for their treatment. The £4 billion that the government puts in from the national team goes to the local team. So for us, the North East and North Cumbria, and then they split that out between dental practices, kind of high street, community dental services who take referrals from dental practice, and hospital-based dentistry. And the patient can't go direct to the community dental service or the dental hospital. Usually they would need to go to the dental practice and be referred on. And actually any treatment that's undertaken in the dental hospital is free of charge. But as I say, the patient can't usually just walk straight into the dental practice. So that's how the current system works. Most of the activity is in the dental practices and the community dental services, what we would call primary care. So that's how we currently have the system. As I've kind of alluded to, it's a bit of a weird system and not everyone's very happy with it. So let's have a think about if we were designing a system from scratch, what we'd want it to look like. And the first question is, what should a dental system or an oral health system actually do? What is the point of the system? What is the aim of it? What do we want it to do? And I just want you now to go back to your screens. And this is a free text one, so you need to enter some text. I want you to put in what you think the point of a dental system should be. Ideally short answers, like a couple of words, and we'll see what comes up with in terms of a word cloud. So start typing and we'll see what we can do. I'll give you a minute or two for this one because it's a bit more complicated to think about. Okay, here we go. Let's see what the word cloud looks like. This takes a little while for us just to generate. Right, okay, so big word there, prevention in the middle, which is good to see. We've got free dental care, accessible, equality, good oral health, provide dental care. There's some of the bigger ones. Prevent disease again, healthy teeth, help the patient, improve oral health, no pain, able to eat, be able to check teeth, treat patients for free. Oh, loads of ideas there, but some similar themes appearing around prevention, access, equality, freedom of care, short waiting. Yeah, so some really interesting stuff there. Thank you very much. Okay, let's move on then. So a lot of people would say, okay, well, the point of any health system is to maximize health. That's pretty obvious, isn't it? But that's really difficult to actually define, because do we mean some clinical measure of disease? Like if we're looking at blood pressure, is it how many millimeters of mercury? That's how we measure blood pressure. How many we reduce that by across the population? Is it the number of decayed teeth that we're reducing? So something very clinical. Or is it more about well-being? Is there some way of measuring quality of life and how happy people feel? Is that what health means? So we have to be really careful when we say maximize health as an objective of a health system, because it can mean lots of different things to different people. And then, as you've just illustrated on that slide, there might be all sorts of other objectives of a health system, aims of a health system. So good access, reducing inequalities, high quality care. We want to prioritize particular groups. It might need to be politically acceptable for the government to fund it. It might need to fit with other health priorities, making best use of the workforce, safe and acceptable. And you can come up with a really long list of objectives. So it's often not as simple as saying, what do we want it to do? Because there might be multiple things we want it to do. And actually, some of these might compete against each other, and we need to decide which is most important. And I'll come back to that idea of prioritizing in just a second. So then the next question is, who do we want to cover in this health system, this public health system, and what procedures do we want to cover? So I've got another question here for your multiple choice. And I just want you to think for a moment about whether the NHS should cover orthodontic treatment, which is moving teeth around to make them look in a nicer appearance, and whether that should be for all children, whether it should only be for those that can't afford it, only for those who really need it, only for those who really need it and can't afford it, or we shouldn't be covering it at all. Okay, so a lot of people said, yes, everyone should. The next most popular was only for those who really need it. and then for only for those who really need it and can't afford it. And a very small number said that nobody should have it at all. And I raised that as a really interesting question because there isn't much evidence that orthodontic treatment actually has any clinical or health benefit, but of course it has a massive psychosocial benefit and quality of life benefit. And there has been a lot of debate about whether we should fund it. And really the question's a bit simplistic because the problem is if we fund orthodontics, that means that we can't fund other things. And really the question should be, is there a better way of spending the money? So this is a system that the World Health Organization used to help governments think about what public systems should cover. And they say there are 3 different elements. So the first element, A here, is who is covered. Now, we could say that we want everyone in the population to have equal access, and that's the way that the majority of the NHS works for medical care. Or we say, actually, we're going to prioritize certain groups, and that's a bit more like what dentistry does. So they say, we'll make it completely free for children, people on low incomes, and pregnant women. And so we only cover certain groups. Other systems might cover different vulnerable groups. So they might say, well, asylum seekers are a vulnerable group, we'll cover them. Homeless people, people with particular medical problems. And so there are different ways of splitting that up. But the first question is about who we should cover. The second question, shown as B here, is about which services we cover. So are we only going to cover really urgent treatment, like if you're in pain for dentistry, like can you only get extractions? Or are we going to cover more advanced things like having crowns and bridges? Or might we cover some super advanced things like having implants? And there's a question mark about which services to cover there. And I just posed you that question about orthodontics. That's a question about which services we should cover. And then the last element, C, is a bit more complicated to think about, but this is about how much the government puts in for each individual patient. So sometimes it'll be completely free for a patient, as it is with general health in the NHS. Sometimes it will be that the government will cover some of the fee. As I've said, for dentistry, they cover about 75% of the fee. They cover about 25% of the fee. And for other things, they might cover between those two. So there are 3 different questions to ask there. And that's a really difficult question about prioritizing different groups and prioritizing different procedures. And I'll show you a mechanism for doing that. So the next question that I'm going to answer is how we should prioritize those different groups. And there are some really important economic terms again here about the idea of opportunity cost. And this is the idea that if we invest in one thing, we have a cost that we've lost the opportunity to invest in something else. So therefore, we have to trade off these 2 things and see which one's the better investment. We also have the idea of marginal gains. So often if you make small adjustments around the edges of things, we might get some small gains that would be better than saying, let's not do anything at all. As I've already said, we might have multiple or competing objectives. So some services might be really good at improving health. Other services might be really good at reducing inequalities. And we might decide which one's more important. And then we've got a final question about who should decide. So this is taxpayers' money. So should it be all taxpayers, the public, or should it be the patients who are actually accessing the services? Or should it be the professionals, the dentists who actually know what's going on here? Or should it be the policymakers who are elected, the MPs, for example, elected to make these decisions for us? And often it's a bit of a combination of all of those. And typically 4 mechanisms have been used historically to allocate resources and decide how to prioritize different things. So the first one is that we just keep doing the same thing that we've always done, historical, and don't make any changes. And you might kind of be chuckling to yourself, but actually that's a very common mechanism, unfortunately. The second approach is called the decibel approach. So those who shout the loudest get the money. And sometimes we see this, that some charities might be advocating for their health area to get more funding. And if they shout particularly loud and make a really good case, they might get that funding. We can do needs assessments, and our public health colleagues will often do that and look at all the data and say, actually, we need more care for this particular thing or this particular group of people. And that is really useful and helps us a lot. But it often still ends up with multiple things that all have a need, and we still need to make a decision about what to prioritize. Or we might decide to settle on a set of core services and say we're only going to fund these very key things. But again, that requires a really difficult decision about what to include in the core services. So none of those are particularly useful. So economics came up with a kind of more pragmatic way of doing it, which was called program budgeting and marginal analysis. Again, don't worry about the name, but essentially we get together a group of stakeholders, really important people. We look at where we're currently spending the money. We then look at what criteria we would use to judge the services against, to say, are these good services or not to invest in? And then we look at which areas we'd like to grow or do more of, which things we'd like to do more efficiently and release some money, and which services we could actually reduce or scale back. And then if we reduce and scale back from some things, we release some money in order to invest in the growth areas. And then we evaluate all those different options, the wish list, if you like, and then come up with some recommendations. And we actually did this for dentistry in England a few years ago in a project called Raindrop, a very nice acronym for the project. And the first thing we did was we asked the stakeholders what we thought the different criteria for any particular new dental service would be. So if we were going to start investing in something like implants, what would it have to be in order for us to think it was good and worthwhile investing? And the panel came up with this list of 11 things, and they weighted them in order of importance. So they said, first of all, the benefit to the patient was the most important thing. They then said whether it was preventative or not was the second most important thing. Then whether it had good economic arguments, the cost benefit, whether it reduced inequalities, whether it was safe and acceptable, and you keep on going down the list. So that was how they said we should judge the services. We then did a bit of a brainstorm, and they came up with a list of different things that they thought we should investigate stopping, and a list of things that we should investigate starting. So you can see some of these. So doing root canal and molar teeth, doing jaw surgery, orthognathic surgery, some of the orthodontic questions, scaling and polishing, cleaning teeth, and having an out-of-hours service. And then in terms of new ideas, doing more public health dentistry in council services, doing more care homework, using cognitive behavioral therapy for anxious patients, better linking our national helpline to practices, dental care for the homeless, more new practices, and providing preventative advice. And what we did is we scored all of those services against the criteria that you saw on the last slide. And the fourth column here with the figures ranging from minus 0.21 to 0.72 were the scores on a +2 to -2 scale, and also the estimated cost of providing these things nationally. So if you look above the red line, you can see that the top three things scored really badly, and we said, actually, we should be stopping doing those. And that released a certain amount of money if we were going to stop doing those, and that would allow us to invest in the bottom four things, which had scored the highest. So that was a way of working out how to reallocate the money within NHS dentistry. And we've put those recommendations forward, and we'll see if they're taken up. We then, once we've decided on what we've prioritised, need to decide what's the best way of providing them. And this is where economic techniques like cost effectiveness analysis come in. We did one here, which is looking at how we provide fluoride varnish in Chile. This was a PhD student who came to Newcastle from Chile, and we were looking at different settings to provide fluoride varnish, which is a varnish we paint on teeth to help protect them. And we were looking at whether it was best done at schools, at nurseries, or at medical clinics. And we worked out that actually you got the most caries-free percentage, so caries is decay. So along the bottom here is the amount of children without decay. So the further to the right, the better. And the cost of that scheme. And you can see that one with the arrow that says fluoride varnish in primary care clinic was the one that gave the most effectiveness for the least cost. So that was really a good one to invest in. And the other ones with the three arrows on were all less effective and more expensive, so they weren't worth doing. So Chile had decided that their priority was to provide fluoride varnish. We then did the work to say this is the most efficient way of providing it. And then finally, once we've decided what and how to provide, we then need to decide how to actually incentivize individual dental team members and patients to actually behave in a way that means that they do what we would like them to do. And this is really complicated. I'm not going to go through the whole of this diagram, but this was some work we did to work out how we would make dentists do more prevention. And you can see there are all sorts of things going on here, how we pay dental teams, how patients pay, whether they come to the clinic or not, what's going on outside the clinic, wider kind of things going on in society, and other things that determine patient and professional behavior. So it's really complicated to try and make dentists and patients behave in a certain way. A lot of people think it's all about what you pay people to do in terms of dentists, but it's not all about that. And it is often about incentivizing the right behavior through guidelines and making sure they've got the right evidence, but also making sure that they've got the right values and are investing in the right things in the right way. However, payment is a big issue, and ideally we would pay for health rather than activity. And that's quite difficult because if we say to the dentist, we're going to pay you to make somebody healthier, well, health's actually quite difficult to measure. And also, which patients are they responsible for? And also, it's not just the dentist or the dental team member that's responsible for making them healthy. So it's quite difficult to then say to a dentist, we'll pay you if you make this person healthy. So although we'd ideally like to do that, we then have to look at other ways of paying. And you often look at paying for activity and saying to the dentist or dental team member, we'll pay you for how many things you do. And I just want you to think, just for the last question here now, if we paid dentists per item of treatment done, so how many fillings they've done, for example, what do you think the effect would be compared to a set fee per patient? So if we said, we'll give you £100 per patient per year for you to look after them, or we'll pay you per individual filling, what do you think some of the effects might be? And I'll just give you a minute or so to answer that. Okay, so people are saying you might get less patients, more treatment, it might lead to higher pay, might decrease the quality, dentists might be less motivated, become more target-driven. So some really good ideas there, lower quality, unnecessary treatment, really interesting. Yeah, so lots of things that might affect what they do. And really, we've got 4 different ways of paying dentists. So the first way would be to just give them a salary and say, we're going to give you, whatever your salary is, £50,000 a year, and just do what you need to do. Or we could say we're going to pay you per filling provided. Or we could say we're going to pay you a set fee per patient per year. That's capitation. Or we could say we're going to pay for your performance, but not on the amount of fillings you provide, but more about the quality of care. Now, we know that with salaried and with capitation, that does decrease activity levels, as you just pointed out in the word cloud there, whereas fee per item increases the amount of activity, but can create unnecessary treatment, what we would call supplier-induced demand. The pay for performance is actually really difficult to determine what would happen because it depends exactly what you're paying for. In terms of which patients they select, on the capitation system, you can imagine that dentists want patients that aren't going to cost a lot to treat. So they try and pick low-need patients, but they also try and register lots of patients. So they'll get lots of patients onto their books, but they'd ideally want low-needs patients. We know with a salaried service, patient satisfaction is higher, but actually the fee per item and the capitation, the provider, the dentist, is incentivized to satisfy the patient. And then the financial risk, really, there's none for the provider and salaried, and the cost to the government is really clear. With fee per item, really, the government might be liable for anything because it depends how fast the dentists work. Whereas with capitation, the risk is really with the dentist rather than with the government because they have to take on enough patients. So really interesting, different ways of paying dentists will have massive effects. So I've just given you a bit of a flavour tonight about each of those questions. So just to summarise, we know that oral health is really important. There's loads of disease that we've got out there, unfortunately. We know that we need publicly funded oral health systems like the NHS because the market for dentistry is what we would call imperfect. And in order to deal with that, we then need to decide what objectives we need to meet, what the coverage should be, how we're going to do that most efficiently, and what incentives to put in place to pay dentists to get the right behaviour. And health economics has some of the tools to help with that, but it is a really complex problem. So that's the end of my slides. So thank you very much for listening and joining in with the questions.